Let me welcome you to our 2019 Dental Therapy Luncheon. And no, this is not a therapy session for people who may be afraid of going to the dentist. This is all about a new concept that we've gotten really interested in. I learned about this a couple years ago at a national health conference. And as we look at ways in North Carolina to meet the unmet needs of citizens, particularly in the rural areas of our state, this whole notion of dental therapy is something we've gotten really interested in. So thank you all for taking time out of your day to be with us to explore this idea and learn more about it with us. If you're not familiar with our work at the John Locke Foundation, just real quick, we have been a public policy, free market, limited government think tank in North Carolina for almost 30 years. Now, if you don't know what a think tank is, lots of people do. My children ask me frequently, like, what do you do? Just sit around and think about stuff all day? Well, yeah, that's pretty much what we do. We think about things, we think about ways to make people more freedom, to get government out of the way, to remove barriers for people to enjoy their freedom and to fully embrace opportunities across North Carolina. And we think about that a lot. We write about it. We've got some of our materials in the back. We have a newspaper that we explore those ideas, and we hold events like this that we talk about this idea. So our real goal and what we really do with the John Locke Foundation is we hope to present information to you for you to think about. And we have decision makers in the room. We have other people that are involved in this profession. So our goal today is to explore this together and to give you a lot of things to think about and hopefully continue this discussion as we explore this further in North Carolina. We have materials at the back of the room. I'd encourage you to take some. We also have, I just wanted to mention this too, Jordan Roberts and Jennifer from the Texas Public Policy Foundation have worked on this spotlight, this research paper on dental therapy that I think you will find extremely helpful. We did a limited run on these for this event because we wanted to make sure that you all had these not only online, but were able to take these with you. If you want more of these, if you'd like to take them back to your colleagues, Senator Davis, if you want to take these back for all of the senators, or Representative Blackwell, if you want these for all of the members of the House, just sign on a card like this and let us know for any of you that would like more of these than we have available today. We will get those to you in the next week or so. So let me tell you a little bit, let me just kind of lay out what we're going to do today and what this is going to look like. First of all, we have members of the General Assembly. We have other very busy people here in the room with us. And so there may be people coming in and out throughout the entire event just to check in, see what's going on before they have to go on to their next meeting. So that's perfectly fine, you know, if you need to duck out a little bit early. The restrooms are right around the corner. There's a water fountain out there as well. There's snacks at the back of the room, so please help yourself. Now, what we're going to do, the way we kind of thought to begin to explore this is we're going to hear from Jordan Roberts, who is the John Locke Foundation's healthcare policy analyst and expert. And I will just, his bio is in your materials. I'm not going to read all that, but I will tell you that if you have any concerns about the future of healthcare, if you have any concerns about the future of North Carolina, we have North Carolina's brightest and fastest rising superstar with us, and that's Jordan Roberts, who we're delighted to have on staff at the Locke Foundation. So he's going to give us an overview, explain exactly what dental therapy is. And then we have Christy Jo Fogarty with us, who has flown in just to be with us. She is the first licensed dental therapist in the country and has been practicing for 15 years. So she's going to pick up where Jordan leaves off and talk to us about what it's really like to be a dental therapist and what the challenges she's had, but also how that's really worked in other states. And then we'll have questions and answers, so be sure to jot down your questions for both Jordan and Christy Jo, and we'll take those. We are videotaping this program as well. Greg's in the back with the camera, and so when we do the Q&A, we'll have a microphone that we'll take around that we'll ask you to use just so we get all of that on tape. We had a lot of folks who had responded that were not able to attend, but I promised I would send them the video. So we want to make sure to capture all of that. Then we'll take a brief break. We'll have lunch brought in. And while we're having lunch, my colleague Mitch Kokai, who is the Senior Policy Fellow at the Locke Foundation, will conduct a panelist. And we have my good friend Sal Nuzzo from Florida, of the free market think tank in Florida, the James Madison Institute. They have had some challenges in Florida as they've tried to implement this dental therapy idea. And then also Also, Senator Jim Perry is with us, and we're delighted to have him. Senator Perry, in a previous life, in his business life, managed dental practices, so he's going to give his perspective to it. And then Christy, Joe, and Jordan will fill in, where maybe they didn't get to in their regular presentation or address some of the other concerns that we've heard. And then we'll have Q&A as well. So we've got a full program for you. Thank you again for being here, and I'm going to turn it over to Jordan.
Good morning, and thank you all for joining us today. My name is Jordan Roberts, and I'm the Health Policy Analyst at the John Locke Foundation. Our mission at the John Locke Foundation is to advance policies that transform government through competition, innovation, personal freedom, and personal responsibility. The topic of our discussion today, dental therapy, will help further those goals. Before I begin my remarks, I'd like to start off by thanking everyone who made this event possible. I'd like to thank all those at the John Locke Foundation who were involved in this process. I'm honored to work with such a dedicated and amazing group of individuals. I'd like to give a special thanks to our sponsors who made this event possible, our good friends at Blue Cross and Blue Shield of North Carolina, Lindsay Stroud with the Heartland Institute, and Patrick Gleason with Americans for Tax Reform. I'd like to give a special thank you to my co-author, Jennifer Minjarez. Her professionalism and expertise on dental therapy made writing our report a real pleasure. I'd like to thank Christy Jo Fogarty, past president of the American Academy of Dental Therapy, for joining us to share her expertise from being a licensed dental therapist. I'd like to thank Sal Nuzzo from the James Madison Institute for making the trip up to share his experience from Florida. I'd like to thank Senator Jim Perry for joining us on the panel later to share his knowledge of the dental industry. And I'd like to thank other members of the General Assembly who took time out of their busy schedules to join us today. Senator Ted Alexander, Representative Hugh Blackwell, Senator Chuck Edwards, and Senator Jim Davis, and I'm sorry if I missed anyone else. And of course, thank you all, the other attendees, for taking the time to join us today to learn about this exciting opportunity. The first time I was introduced to the topic of dental therapy, I was not quite sure exactly what a dental therapist does, as I'm sure is the case with many of you all. And when I've talked to others who aren't familiar with the topic, the term dental therapy usually elicits an image of a patient in a therapist's office being asked questions about feelings or anxiety related to their teeth. But that is not the case. Dental therapy has nothing to do with actual psychology or psychiatry, as the name may suggest. Dental therapy is a relatively new profession in the United States, which will increase access to high-quality dental care. In collaboration with our partners, we at the John Locke Foundation are proud to help start the conversation to bring this profession to North Carolina. Our goals today are to introduce the topic of dental therapy, give you all an insight into what these professionals do, explain the benefits they can offer to North Carolinians, describe the experience of other states who have tried to introduce this profession, and potential roadblocks a state may face when trying to start dental therapy. In addition to today's presentation, we have also published a report on the potential of dental therapy in North Carolina, which I hope you all will grab a copy of so you can learn more. So what are dental therapists? Dental therapists are highly trained, mid-level dental practitioners who operate under the supervision of a dentist and specialize in preventive and restorative care. Their scope of practice resides in between that of a dentist and a dental hygienist. Dental therapists can perform a wide range of services, which makes them valuable to the entire dental team. They can perform additional services in an office, which will allow the dentist to focus on more complex procedures. In addition, based on the supervision agreement between the dentist and the dental therapist, they could travel to underserved areas and treat patients that may lack the means to make it to a dentist's office. This added mobility allows dental therapists to travel to places that are more convenient for patients, such as rural clinics, nursing homes, and schools. This is a key point as we will discuss the access problem that many individuals in North Carolina face regarding proper oral health care and potential regulation for this profession. In sum, dental therapists are well-trained, high-quality professionals that can provide care while patients do not have to sacrifice any of the quality or safety they deserve. So why do we need dental therapists in North Carolina? Insufficient supply and cost are two of the main barriers that populations in North Carolina face when it comes to receiving the appropriate oral care. The lack of proper oral care disproportionately affects those in rural parts of the state, American Indian populations, low-income residents, children, and senior citizens. In addition, North Carolina has over 2 million enrollees on the Medicaid program, which offers generous child and adult dental benefits compared to other states. However, the fact that dentists in a particular area may not accept Medicaid as insurance or may not be accepting new Medicaid patients can exacerbate the problem of dental professional shortages. Increasing the supply of dental therapists can help address the access and financial barriers that these underserved communities face by increasing both the supply of dental professionals and lowering the costs through enhanced competition among providers. Currently, 10 states allow dental therapy in some capacity. North Carolina could join these pioneer states in allowing the profession of dental therapy. So what is the dental problem in North Carolina we are trying to address? In our report, there are a number of demographics and factors that we look at as it pertains to dental care in North Carolina. I'll start with the rural areas. The rural parts of our state disproportionately lack an adequate number of health professionals compared to urban and suburban areas. 80 of North Carolina's 100 counties are considered rural. According to the North Carolina Department of Health and Human Services Office of Rural Health, 59 of North Carolina's counties lack the proper supply of primary care physicians, mental health professionals, and dental professionals. However, pertinent to our discussion today is the fact that 74 of North Carolina's 100 counties lack the proper supply of dental professionals to serve the surrounding population. For example, a report by NC Child reports that as of late 2017, Camden County, Hyde County, and Tyrrell County didn't have a single dentist. Bertie County, Gates County, and Jones County and Washington County each have less than one dentist per 10,000 individuals. With median incomes lower in rural counties compared to urban and suburban counties and the lack of dental health professionals in the area, rural residents can face difficulty in accessing the proper oral care they need. Next, the American Indian population here in North Carolina is the largest of any state east of the Mississippi. This group can face significant barriers to access of proper oral health care because they tend to live in more rural parts of the state where health professionals are scarce. A report by the North Carolina Department of Health and Human Services Office of Minority Health and Health Disparities states that North Carolina American Indian children are almost twice as likely to enter kindergarten with some form of tooth decay compared to non-Hispanic white children, a concerning statistic. Now consider children and those who rely on Medicaid for health coverage. The research is clear on how important oral care is for children. The lack of proper oral health at a young age increases the chances of persistent health problems throughout their life and may even affect school performance. In addition, children from low-income families are twice as likely to have tooth decay compared to those from high-income families. The oral health section of North Carolina's Department of Health and Human Services reported that 14.3% of all kindergarten children had untreated tooth decay between 2016 and 2017. This is lower than the national average, but still far too high. The North Carolina Medicaid program offers robust child and adult benefits compared to other states, yet children on Medicaid are less likely to have dental visits than those with private insurance. Less than half of the Medicaid recipients under the age of 21 received dental care in 2017. And this could be for a number of reasons. It may be that many areas lack an adequate number of dental professionals, or it may be that Medicaid patients find it hard to locate a dentist that accepts public insurance or new Medicaid patients. As of 2016, only 29.7% of dentists in North Carolina participated in the Medicaid program, which is far below the national average. The senior citizen demographic can be affected by the lack of dental professionals or unaffordable care in the area as well. It's no secret that we have an aging population. Individuals are living longer because of advancements in modern medicine, and the longer they live, the more oral care they may require. It is more likely than not that a senior needs some form of dental treatment. They're more than twice as likely to have gum disease, and compared to white seniors, black seniors are twice as likely to have untreated decay or gum disease. Lastly, no matter what population we are talking about, dental therapists may have an effect on the utilization of hospital emergency room visits as well. In areas of the state that lack the proper number of dental professionals, if an oral emergency occurs, the emergency room at the local hospital may be the only place to receive care. Emergency rooms can be one of the most expensive settings for a patient to receive care. Data from the North Carolina Oral Health Collaborative shows that here in North Carolina, between 2007 and 2013, we had a per capita rate of emergency room dental visits, which was more than twice the national rate. On top of this, North Carolina had the fastest growth of emergency room dental visits compared to our southern neighbors, such as Tennessee, Kentucky, and South Carolina. Addressing oral health issues before they get to the point of having to go to an emergency room could help save individuals and the state money, as well as scarce hospital resources. So here's the most important question. Will these new dental health professionals help these underserved communities that we have just discussed? The results from other states speak for themselves. Data from Alaska and Minnesota in particular show that the positive outcomes that can be achieved if a state allows the practice of dental therapy. Dental therapists in Alaska have been practicing for over a decade, and as of September of 2018, the state had over 30 dental therapists on the ground practicing. Over 40,000 Alaskan natives in 81 rural communities saw increased access to dental care. Studies from Alaska show after the introduction of dental therapists, communities served by these professionals saw increased access, decreased wait time, more children and adults received preventive care, and fewer young children had front teeth extractions. In addition, dental therapists were found to be technically competent, comparable to dentists, and they operated safely and appropriately within their defined scope. The results from Alaska are mirrored in Minnesota. Minnesota licensed its first dental therapist in 2011, and as of April of this year, there are 93 practicing dental therapists. Studies from Minnesota found that at observed clinics, dental therapists treated over 6,000 new patients, 84% of whom had public insurance. Some patients experienced lower wait times and decreased travel times. Clinics found that utilizing a dental therapist led to personnel cost savings, increased dental productivity, improved patient satisfaction, and clinics were able to treat more underserved patients. Another study in Minnesota found a proportional distribution of dental therapists within the state, with over 40% practicing in non-metropolitan areas. Given the data we discussed before, there is no doubt in my mind that the introduction of the dental therapy profession in North Carolina will bring about positive benefits for underserved populations in the state. The experience in Minnesota and Alaska shows that rural populations, those with public insurance, and those who have a hard time affording dental care could benefit from an increased supply of dental professionals who tend to serve these demographics. So how can we bring dental therapy to North Carolina? This new profession could be introduced in North Carolina by legislation that amends Chapter 90 of the North Carolina General Statutes. Chapter 90 of the North Carolina General Statutes regulates medicine and allied occupations such as healthcare providers, dentists, pharmacists, and other professions related to health. By simply amending this statute to grant the North Carolina Dental Board of Examiners the authority to issue and oversee licenses of dental therapists, North Carolina could become a leader among southern states in allowing this practice. It will take time for the process to unfold and to get dental therapists on the ground practicing. First, legislation must be passed to create a new license designation for this profession. Next, educational institutions must create a curriculum and seek accreditation from the Commission on Dental Accreditation. Upon becoming accredited, institutions may enroll and educate students, and then once students meet educational requirements and they receive a license, they may begin practicing. Only after this can dental therapists enter into the delivery phase. Another key to this whole discussion is the regulatory framework for dental therapists. Lawmakers should keep in mind that the regulations placed on these individuals will greatly affect their ability to practice. For a more in-depth look at the policy proposals we are suggesting, please see the report, which has a detailed chart. But in short, the regulations around this profession will dictate, among other things, the supervision requirements, required level of education, scope of practice, the ability of dental therapists to supervise dental hygienists, and other patient requirements. The regulatory framework governing these professionals should be flexible and allow for as much practitioner freedom as possible. If the restrictions are too rigid, North Carolina will not be able to enjoy all of the benefits of dental therapists. Responsibilities should be decided between the dental therapist and their supervising dentist with a minimal level of government barrier. As I've said before, this process will take time. The introduction of dental therapy in North Carolina will not solve all of the problems for residents of the state when it comes to provider access and costs associated with receiving care. However, this is a supply-side reform that has been proven effective in other states to increase access in underserved communities and provide high-quality oral health outcomes. Not only could dental therapists help treat these populations, they are also cost-effective practitioners who can help with the financial stability of existing practices. Allowing the practice of dental therapy can begin to help the at-risk populations of the state through a greater supply of dental professionals who specialize in the preventive and restorative care that is critical for sustained oral health. So, while the topic of our discussion today and the problems with access to dental care for many North Carolinians is very serious, I would like to conclude my remarks with a couple of dentist jokes. What are the 7 scariest words in the English language? The dentist is ready to see you. A dentist says to a patient, "After this root canal, you will feel like a new man." And the patient responds, "Sounds great, doc. While you're at it, can you send the bill to that other man as well?" And my favorite one, what is the best time to go to the dentist? Tooth hurty. And with that, I would say the best time to bring the dental therapist profession to North Carolina is right now. Thank you for listening, and I hope everyone enjoys the rest of today's luncheon. I'll now pass it back to Becky.
Thank you, and thank you all for having me to your beautiful state. It's 45 degrees and raining in Minnesota, so any excuse I can have to get out of that weather, I will take. I'm just going to start by telling you a little bit more about me and my background. I've been in dentistry for just about 25 years now. I am the perfect example of career laddering and how it worked in Minnesota. I started out as a dental assistant. Once upon a time, I was a newlywed, and my husband said to me, "You need to get a real job." At the time, I was bartending and waitressing, and my non-real job paid for him to finish college. So, thus started our first fight. But he revised his statement to say, "I think I'd like you to find a job more conducive to family life." He's a Minneapolis police sergeant and knew his hours would always be a little crazy, so he saved himself a little bit. But at the time when I was bartending and waitressing, we were in a lower level, our restaurant was in a lower level of a building that housed a lot of dentists, and every day the dentists would come down to lunch and I would wait on them, and I said, "You know, I think I'm gonna go back to school, and I'm looking at nursing, I'm looking at dental hygiene, I'm looking at dental assisting. What do you guys think?" And one of the dentists said to me, "You've got great hands, but you don't know if you love dentistry. So I would encourage you to do dental assisting. It's 11 months of training. It's not a lot of time, talent, or treasure you're putting into it to see if you like the profession. And if you do, I would encourage you to go on to hygiene school because you're gonna really find a lot of enjoyment in that career." So I took his advice and I went to school to become a dental assistant. I was about halfway through the program when I realized I loved dentistry. I had found my part of the world that I wanted to work in. Before I had even graduated from dental assisting school, I was applying to hygiene school. Of course, that was at a time where about 400 people a year were applying for 30 spots, and it was very difficult to get in. So it did take me 2 years to get in. So I practiced 3 years as a dental assistant while I was going to school for dental hygiene. When I came out of dental hygiene, I worked for a dentist who very strongly believed in giving back to the community. He was a private practice dentist, but he took a fair amount of public assistant patients. And I really, if you'll forgive the pun, cut my teeth in hygiene on some of the hardest patients that you can see. So anyone who practices in dentistry, a lot of immigrant patients. I had one gentleman who was 65 years old, and it was the first time he'd ever been to the dentist, and I was cleaning his teeth. So it was very rewarding, very hard work. But start to give me some glimpses into those who struggle to get into dental offices. After that, I spent about 7 years doing independent contracting. My family was growing, and I didn't want to work quite as often, but I wanted to never step out of my career, and that gave me an opportunity to work when I wanted and pass on opportunities to work when I didn't want to. In that capacity, I was able to work all over the state of Minnesota. I worked in really rural areas. We live in kind of the southern part of the metro. It gave me access to the southern part of the state and a lot of rural areas. Certainly the metro area and certainly suburban areas. And one theme that was common among all of that was the lack of access to dental care, especially for those who were uninsured or were on state programs. And I'm never one to stand up and beat on dentists for not taking those public assistance programs. They're tough. The state of Minnesota has, depending on how you look at it, the second worst or the worst reimbursement rates in the country. And quite often when dentists take those patients into their practices, they're doing so at a cost to them. It almost always ends up costing them. But I saw that general theme, and it was very hard on me. And at the time, Minnesota was starting to talk about dental therapy, and the reasons that we did it were for certain to help open that access to care, and it was something I was very intrigued with. So I'll talk to you a little bit more about how the legislation came to be in Minnesota. Minnesota had several counties that were national dental shortage areas. We even had several urban areas that were declared the same way. As it happens, the hygiene instructor I had was now the head of the department at Normandale Community College. Her name was Colleen Brickle. And as they were talking about what to do with this legislation, they talked about, do we come up with the curriculum for it first for dental therapy? Of course, it wasn't called dental therapy at that time. I'll have to, have you look at my resume, and you'll see that I have a degree, actually a master's as an oral health care practitioner. That's really what they wanted it to be, a lot like a nurse practitioner. But do we do the education piece first, or do we do the legislation piece first? And that's a question that a lot of states that I've realized have come to grapple with, which is the best way to go. Fortunately, for states who are considering that now, CODA has come up with requirements, and that path is a little bit easier to navigate. I think it's easier for states to pass legislation first because there's now a map for the education piece that didn't exist when they passed it. In Minnesota, they did pass the education piece first, which turned out to be brilliant. Colleen submitted it through the MINSCU process, which is our public university process for approving curriculum. And what happens is you put that in, and for 30 days, people can comment on your proposed curriculum before it passes. Any comments are taken, they're debated, and she expected that. So she put it in, and she waited. And on day 29, not one comment had come in. And she couldn't believe it when she woke up the next morning and 30 days had gone by and not one person had said one thing. Thus, the education piece in Minnesota passed very quietly. And then they went to move on to, of course, the education piece. And if all of you can remember way back to the first Surgeon General report on oral health, one of the backup findings to that was to help expand the dental force, because they could even see back in 2000 that we were going to have issues in dentistry with the lack of providers, and that there was going to be a need to find some kind of an expander profession. So even way back in 2000, they were visualizing that. And they talked a lot about that in Minnesota when they were trying to get the legislation through. And they talked to a lot of organizations. And one of the things that they did very well in Minnesota was they talked to peripheral organizations that certainly always felt that dental piece missing, that so many of their partners could not find dentists, social services. And in the end, when it came time to talk to legislators, we had 50 organizations that supported dental therapy in the state of Minnesota when we went and talked to those legislatures. In fact, there was a huge one-page ad that was taken out in our local papers that listed all of those organizations as for dental therapy, and in opposition was only the ADA and the Minnesota Dental Association. It was a very powerful piece. It was a very good way to help legislators understand that this was important to not just dentistry, but to the public at large. So that's kind of how we got to our legislative piece. I'll talk a little bit about our legislation. First, I'll tell you what scope of practice is. We have a little bit of a different thing, and I'm going to try not to confuse you because it's so easy to confuse you, but we have actually dental therapists and advanced dental therapists in the state of Minnesota. And the main difference is supervision level. So when you graduate from your accredited program, you are a dental therapist, and then you will work 2,000 hours as a dental therapist under indirect supervision, which means the dentist does not necessarily need to observe all of the work that you're doing, but they need to be present in the building when you're doing the work that you're doing, and they need to be aware of what you're doing. So that's what indirect supervision means in Minnesota. So you spend 2,000 hours doing that. After that, you go through a 3-part process with the Minnesota Board of Dentistry. Once you have completed successfully those 3 pieces, you're giving your credentials. As an advanced dental therapist, it's just a credential that sits on top of your license. I was the first one to go through that process, having to constantly call the board and say, I'm at this many hours, you guys got to get that exam ready, because in the process, they're trying on the other side the rules and regulations of how to get this done, right? How to make sure that they're protecting the public and making and ensuring that we are good quality practitioners. After that credentialing process, you can then work under general supervision, which is really, really the linchpin of how we can just explode access to care. I can now work under general supervision, doing everything within my scope of practice, and the dentist just needs to be aware of what I'm doing. They don't need to be in the building. Quite often, I'm 3-4 hours away from my collaborating dentist. We call him a CMA dentist. It's a collaborative management agreement that we have. Consistently communicating with them and talking to them through digital means, teledentistry, multiple different means, but they do not need to be in the building when I'm performing. So in Minnesota, we can do any kind of filling, anterior, posterior, primary teeth, baby teeth, adult teeth. I apologize if I use dental terminology. I don't always talk in front of people who don't understand what I'm saying. We can do extractions of baby teeth. We can also do limited extractions of permanent teeth. For those in the room who do speak dental, it has to be a class 3 mobility. For those who don't, it has to be squishy in the socket. I know that's maybe a little more than you needed to know before lunch. We can do any kind of space maintainers. And we can do a few things that are kind of odd and interesting. We can do brush biopsies. We cannot fabricate dentures, but we can do soft relines of dentures. Very helpful for our geriatric patients. And another big linchpin that really helps us out is we can do examinations. We don't have the word diagnosis in our legislation, but we do have assessment and individualized treatment plans. And for those of you who work in the dental industry, that means that we can go in, take the x-rays, do the complete evaluation, and then immediately begin starting the work. So it really helps those patients. I'll talk a little bit more about the education that we receive. I have a bachelor's in dental hygiene. I have a master's degree. To be an advanced dental therapist in the state of Minnesota, you have to have a master's degree. The testing that we go through, we take a clinical board. Part of it is on a mannequin, just like a dentist has. It's a fake set of teeth where we do a baby root canal. On a primary tooth, we do a couple of temporary crown preps for the stainless steel crowns. But when it comes to the clinical piece that is on a live patient, it is the exact same examination that a dentist takes. So when people are evaluating our clinical skills on a patient, they don't know if they're looking at a dental student or a dental therapy student. And in our scope of practice, in our training, we are trained to the level of a dentist. And I'm going to repeat that because that's really important. Our scope of practice is maybe 12% of what a dentist can do. Fortunately for dental therapy, it's the most needed procedures. But in that scope of practice, that very limited scope of practice, we are trained to the level of a dentist. So it's really important, and we are tested to the level of a dentist. So it's very important to understand that safety standard that's there and that high level that is expected of dental therapists. So I work for an organization called Children's Dental Services. We work much like a hub and spoke. I'm headquartered in Northeast Minneapolis. And we have about 300 sites that are in our major metropolitan area. We have like a 7-county metropolitan area. And we have about 500 sites statewide. We are a very large organization. We see about 35,000 children a year. We see children under the age of 26 and pregnant women. And I myself see about 6,000 children a year. So if anyone doesn't think that impact of dental therapy, even though we are still small in numbers, as Jordan said, there's only 93 of us so far, we are making a huge impact where we're able to really get in there. And like I said, it's very common for them to send me from my home in Farmington, which is just south of the metro, 3, 4, 5 hours away to one of the corners of the state where there may not be a dentist, or a dentist is unable or unwilling to see people on public assistance. It's not uncommon for me to work there for an entire week serving that population. I apologize. Struggling with a little bit of a cold here. Our legislation also requires that at least 50% of our population that we see is either uninsured, they called it uninsured, underinsured, or on public assistance. I don't know what underinsured means in dentistry. If anybody can tell me what that means, I'd be very happy for that definition. Thank you so much. So today we have about 93 dental therapists working in Minnesota. About half of us are advanced dental therapists and have that advanced ending. Most of them are still working towards their hours. And in Minnesota, when I first started out much like maybe a dental student did, right? I would go in and I would do the prep, I would get all the decay out, I would have the dentist check it. This is kind of how they eased us into knowing how to practice in a dental office. That's not how they do it anymore. They completely trust that the dental therapists have been 100% trained in their scope, and there's not that kind of supervision anymore. Very large acceptance. There are several dentists who spoke at the legislature when the legislation was going through about how this would be the end of dentistry, who now have dental therapists working for them. And we find that the number one person who wants to hire a dental therapist is someone who already has a dental therapist working for them. And with the Minnesota Dental Therapy Association, they send out job opportunities that are going out. There are far more job openings than there are therapists. We literally can't graduate them fast enough to fill the openings in our state. So in 8 short years, we have seen a complete 180 turn on this profession. There's always going to be some out there who think that this isn't something we should have done, but I think that most of them will concede that we are safe, quality practitioners. So right now, there are 8 states that allow some type of dental therapy practice to happen. Some is limited to certain areas, some are done in pilot projects. But Minnesota still remains the one state with codified practitioners. Of course, the state of Alaska, who probably got this whole ball rolling, will celebrate their 15th graduating class next month. And the first 2 classes that came out of New Zealand, actually came out of New Zealand. They sent them to New Zealand to train. And over 20 states this year considered dental therapy legislation. So I think one of the things I want to talk to you about is I just want to tell you kind of a story that reflects much of what Jordan just said. I was a dental therapist probably about 6 months out, working in our main clinic, and we had a mother come in with a 2-year-old little boy. He had fallen the week before. He had been up the entire night before. He'd hit his two front teeth when he'd fallen. He had been up all night with pain. She hadn't slept, he hadn't slept, and she had spent all morning calling dental offices. And she came in and sat down and she said, "Thank you so much for seeing us. I called a dozen dental offices and no one would see him because we're on public assistance and he's under the age of 3. She said, "My next stop was going to be just take him to the emergency room," whereas Jordan talked about it's probably the worst place you want to take a 2-year-old for a dental problem, right? They're going to give him antibiotics, they're going to give him pain medication, and they're going to tell him to find a dentist. So tremendously expensive to not even resolve the underlying condition or problem. So we were able to get his 2 front teeth out. The only option we had was to extract it, and Mom cried and the kid cried, but they got through the appointment, and I said, "I'd really like you to bring him back so we can do an evaluation. We, do a full comprehensive exam. We dealt with his pain today, but let's start getting him in for regular dental appointments and make sure there's no other decay." So about 2 weeks later, I'm standing in the hallway, and this little guy comes wheeling around the corner, and he stops, and he looks at me, and I thought, oh, here we go. He is just going to start screaming, right? Because that's it. I'm the lady who made him cry. And he looked at me and he came running up and he just wrapped his arms around my legs. And his mom came up behind him and I said, "Boy, that's not what I was expecting. I was expecting some tears." And she goes, "All he remembers is you're the lady who took his pain away." It didn't matter to that mother what letters I had after my name. What mattered to that mother was that she had access to dental care, a way in which to get her child out of pain and healthy. So when people talk about whether or not dentists should allow dental therapists or should oppose it, I think you can understand the public just wants good, quality, safe care. And I think that that's something you can probably offer in North Carolina.
Okay, great. Okay, who has a question? We'll start. Yeah.
Thank you. I've decided to overcome my natural reticence and go ahead and ask a couple of questions. Thinking about what was just said regarding what happens to the young boy who had he been taken to the emergency room, and thinking back to what Jordan said about the percentages of visits in North Carolina to emergency rooms for dental issues, is it in fact the case that if you go to an emergency room at a hospital in North Carolina with a dental problem, that it is going to essentially follow the same pattern that was described? You don't really get the dental problem addressed. You get pain medication, antibiotics for an infection, and then you still have to go find a dentist.
Yeah, no, I think that's exactly what we see a lot of times. The actual issue doesn't get addressed, and they may be visiting over and over again, which just racks up expenses for the family, for the state, and so, you know, like I said, increasing the access to address these problems before it gets to the point of going to an emergency room, or just having that consistent level of care, you know, that's really the goal here, and I think that it could be alleviated a lot with an additional supply of dental professionals.
And second question, both of you had positive comments about the experience following approval of dental therapy in Alaska and Minnesota. There was a little bit of a reference to what I'm going to ask about in your remarks, but are the dental societies in those states in agreement with your assessment that the outcomes have been in fact positive? Are they now supportive of this, or is there still significant opposition from dentistry?
So I'll answer a little bit differently. So just so people understand, in Alaska, it's a little bit different. It's not codified into their state law. It's a special federal program just for the indigenous people there. I mean, you're literally talking about people who have to take a boat or a plane or a snowmobile to get to a dentist, hundreds, if not thousands of miles away up there. I mean, it's very vast, it's very deep. So they're not codified in state law. I don't think there's ever been any opposition from their Alaska Dental Association. The ADA certainly, I mean, obviously they fought them, they sued them, but that has not been much of an issue because they don't practice in Fairbanks or Anchorage. They're really in these small villages. So I'm not sure that answers your question, but there's just not really any friction there. In Minnesota, I would say that the Dental Association has come 180 degrees. Not only are they supportive of dental therapy, the Minnesota Dental Association and the Minnesota Dental Therapy Association quite frequently work together on different projects. Everything from free dental care to legislation, hoping to improve reimbursement rates for public assistance patients. We work with them regularly. We're invited to all of their organizational and planning sessions. It's actually a very close working relationship. We were fortunate in two things. One, the last president of the Minnesota Dental Association had a very good friend whose daughter became a dental therapist. And he literally would pay for her to go to dentist-only organizations and invite her to speak. So he really did a great job of helping expose many of the dentists in the state to dental therapists. And I think most dentists who don't want to hire a dental therapist, obviously it's not a mandatory legislation, right? No one's going to be forced to hire a dental therapist. I think it's a good financial decision. I think it's a good decision on many aspects, but I think they've realized it really doesn't affect their practice at all. We're not seeing the patients they see. I see about 93% people who are on public assistance. Most dentists are unwilling or unable to take those people into their practice. So certainly there's no opposition currently in the state of Minnesota, and it probably hasn't been for 3 or 4 years.
My name is Mike Rugabeni, and I just want to give you a little background so you know where I'm coming from. I'm a dentist. We have 20 offices. Half of our offices are in rural communities, and we accept Medicaid. So I'm listening to what you're saying, and I don't have My mind's not made up. I want to hear what you have to offer. But I am very interested in the education that you have as a dental therapist. So you said that you were a hygienist, you were an assistant, then you were a hygienist, then you got a master's. What is the normal educational process for someone right now? I just graduated dental school and I want to be an advanced dental therapist. What's my next steps?
Okay, so
I just graduated high school.
High school.
Yeah, I just graduated high school. What's my next step?
Okay, so in Minnesota, there's 2 educational programs.
Okay.
There's one through Metropolitan State University, and there's one through the University of Minnesota's Dental School.
Okay.
So Metropolitan State University will only take current practicing hygienists with a 4-year degree in dental hygiene. Okay, so you would have to go on to college to get a 4-year dental hygiene degree to be even considered to be accepted into that program.
Right.
You also have to have practiced a certain amount of time. I will say that Metropolitan State University, which is where I went, significantly less expensive than the University of Minnesota. I mean, obviously the University of Minnesota is a private institution, and Metropolitan State is a public institution, so a little less, about half the cost. So if you are a licensed hygienist, that is the path that you would want to go. If you want to get into the University of Minnesota's program, there are 10 prerequisite courses that you have to take to even be considered into the program. And their current program that they have, now there's been different renditions, so if you hear different things, those quite possibly would be true from the past. But currently their program is 10 prerequisite courses. You're accepted into their program, and you will come out dual licensed as both a hygienist and a therapist. So you'll matriculate somewhere in that program. I believe it's December of your last year. You'll matriculate with your bachelor's degree in dental hygiene and take your dental hygiene boards. And then in May, you'll matriculate with your master's degree in dental therapy, and you'll take your dental therapy boards.
So that's 6 years?
6 years.
Right. So you're going through 4 years for dental hygiene degree and then 2 years for your master's. So that's 6 years.
Correct.
So a normal dentist would go to 4 years of undergrad and 4
Yep.
years of dental school. So we're talking about 2 less years of education.
Correct.
To do 12% of what a dentist can do.
Correct.
With just 2 more years of education. So my question is the cost of education less than going to dental school? Because part of what drives costs in North Carolina is we have students graduating with $400,000 to $700,000 of student debt. And the cost of setting up a dental practice, whether a therapist is going to be doing or a dentist is going to do it, is going to be the same. So there has to be something, where are we going to save the money? Because from my perspective, if you can increase the number of dentists that can do 80% more, I'm just thinking out loud here.
Absolutely.
If we can increase the number of dentists that can do 80% more for 2 extra years of education, and the costs are going to be the same, where are we saving the money in this?
So as you know, as a dentist, dentists are among the most expensive professionals to educate. So when you ask about is there savings in the education piece, absolutely. So undergrad credits, obviously those 10 prerequisite courses, much less expensive. Those graduate courses, more expensive. Once you're accepted into the university's program that dual licenses you, it's about $80,000. So pretty significant compared to their dentists that are coming out about $250,000 in the University of Minnesota's case. Most of those students are coming out about $250,000. So a significant expense for that student for those second 2 years, right? You're not wrong about starting out a dental practice. Very, very expensive. But I can tell you this, there was a dentist in Minnesota, his name is Dr. John Powers, and he sent his dental assistant to the University of Minnesota to be educated as a dental therapist, okay? Helped her, paid for it, she's a single mom, great story. And he's in rural Minnesota, and he had her come back with the idea of, I don't need her to make money for my practice, because this is just something he really felt strongly about. I just need her to cover all her expenses so I can serve my community more. He had a large population of people who had Medicaid in the community. He was the only dentist who took public assistance, and he wanted to serve his community more. Just a very altruistic man. Unfortunately, he has passed away. But he was shocked at the end of her first year. She made $20,000 for the practice, right? Great. Covered all her expenses, made a little bit of money. But what he hadn't anticipated was how much it opened up his schedule. Is he was able to put more implants in that year than he was ever able to before. He was able to do more crown and bridge work than he was ever able, and the practice made $200,000 more. So they can help with those expenses because you have this provider who doesn't cost your practice nearly as much, but can produce at a pretty high rate. at the same time giving access to those people who most need it. I mean, I really do commend you, because I do think it can be a hard struggle to sometimes accept public assistance payments into your practice. It's a challenge, and I really commend you for doing it.
What's the average salary of an advanced dental therapist?
So advanced dental therapists, once you get that credentialing, the average starting salary is about $45 an hour. That's going to vary a little bit here and there. There's some that are paid on production, some of us that are paid on production. Some are, been practicing for a while, but generally speaking, once that certification is reached, it's about $45 an hour.
And when they're paid on production, what percentage of production?
That
what's
I
the
can't
average?
answer, because I don't work on production. If you want to take one of my cards and reach out to me, I can have the Minnesota Dental Therapy Association. They have better handle on those numbers, and they can get that back to you, because there's several that do.
And my final statement is that in the offices that we have in rural areas, our profit margin is probably about 10 to 12%. So unless the cost of assistance, because you're still going to need an assistant, you're still going to need front desk people, unless all those other costs decrease along with the cost of the actual therapist. And by the way, if they're paid on production, we're not necessarily sure that that cost is going to go down. But if you guys can prove that all those costs can decrease, then I think you have something there. But if we're just replacing dentists with people that can do 80% less work, and we have all the same challenges in terms of cost of materials, cost of labor, then I'm not really sure this is the solution.
Thank you. Who else?
Hi, I was just curious. You said about 20 states have considered legislation similar to this. How many of them have the clause about 50% of patients have to be uninsured, underinsured, or on public assistance?
Virtually all of them.
Okay.
Yeah, it's a pretty common clause that's being put into the legislation, for certain, because it's driven to help open access to care. Yep.
I'll ask a question. When we see, we talk about one of the main reasons to consider this is access to care, particularly in the rural areas. How does that look like in Minnesota? Because dental therapy's been around for how long? And we should see some results there.
Yep.
What do we know about that?
So our legislation passed 10 years ago this month. In fact, I started school 3 weeks before the legislation was signed, so it took a little bit of a leap of faith. But Minnesota has become actually remarkable in how much our dental therapists and the locations of where they work and the people that they serve are very reflective of our state itself. So our state has about 59% of its population living in the metropolitan area, and about 55% of its population living in the metro area, and 59% of therapists working in that area. And the inverse is true, 45% and 41% are in the rural area. So we have become very, very evenly distributed. One of the advantages, and one of the things we learned early on, is my program at Metropolitan State University. We got a request very early on from dentists, can you get them through any quicker, right? Our program was about 26 months. That program has been condensed down to 16 months. So it's a very short time. People from rural communities are leaving to become educated to go right back to their communities, and that's usually what we're finding, is that they've already got a destination in mind, and they're really just coming to get the education to go back and serve their communities. And if you can imagine the difference between 16 months and 4 years of dental school, and when you add that with 8 years of undergrad that most people spend from their hometowns, it's quite frequent dentists don't end up back in their communities, right? How many of our kids have gone off to college and never come home? It's just the nature of the beast.
And I was going to add, in our report, there's a figure of Minnesota to show where the professional shortages are and where dental therapists are practicing, although it doesn't reflect all of the mobile sites, too, that are on the ground in Minnesota.
Because when they look at those numbers, I'm counted as a metropolitan dental therapist, and I very rarely work. I mean, it's not uncommon for me to spend 2, 3, 4 months and never set foot in our Northeast headquarters. I certainly serve some urban areas, but I also serve a lot of rural areas, but I'm counted completely. The count goes completely by where you are, the headquarters of where you practice. And Apple Tree Dental is another organization that does kind of the same thing, and they're all counted as metro employees, unless they are specifically at one of their outstate locations. They have about 6 locations throughout the state.
Yeah, great. I have a couple of questions. Can you talk a little bit about the training and education on the Alaska model, which has been successful for 15 years, and talk about how different that is from the Minnesota model?
You obviously know the difference. It's significantly different. So when you talked about what do I do right out of high school, the Alaska model is 2 years of training directly out of high school. And they have a larger scope of practice than I do. So again, you're talking about people who have to take planes and boats and snowmobiles, but they have come up with what they used as the New Zealand model. They don't do any hygiene. They don't have dental hygiene training other than to recognize things like perioabscesses and significant periodontal disease. But I have a good friend who works in Ketchikan, and it's not uncommon for her to remove wisdom teeth that are not impacted and not surgical.
Great. That was my first question. And the second one, it has to do with, you said that many of the states require, state that the therapists need to work on underserved populations or specific populations. Do you have any concerns about equity and justice?
In what sense?
In terms of, well, these people you guys can treat, but these
That
people
insured
you
people
can't.
won't have as
Okay,
much
yeah.
access to dental therapists?
No, it's just is it a two levels a system that's really looking at two different populations. You guys can get a dentist, you guys can get a therapist. I mean that's.
I've never
look,
had
that's the
anyone
question.
ask me that question before.
Okay.
I might have to noodle that a little bit. I can tell you that in Washington State, that very issue was brought up. They had come to an agreement with the tribal people there that they would pay the fees of dental therapists that were on public assistance programs. And they had come to an agreement that they would then not seek legislation outside of those Indian tribal lands. And the federal government came in and said, you can't do that. You can't say just tribal people can have it. So you're not the first one to think of it. I've never had anyone ask me that. I just want everyone to have dental care. Let's see, were you?
I just had a question. You said that it changed from 6 months of training to 16 months training.
Correct.
Is that after you have your BA in?
After you have
Have your BA in
dental hygiene.
RDH? Okay.
Yep.
Thank you.
Yep. It's just a 16-month master program versus a 26-month. The University of Minnesota, when they're coming out dual license, they're still at 26 months for their program because they're getting that dual license, and you're not sitting on top of a degree yet. I mean, 10 courses is a significant amount of work, but.
So a lot of universities, specifically in North Carolina, have cut down their their bachelor's programs to 3 years. There's a lot of dual options. They call them like 3-2 or 4-1 or things like that. Do you see that as part of the future of this in cutting down the costs, like you so adequately explained, so that the cost for education be cut down so that more affordable dental care providers can go to these rural areas?
Well, I would certainly hope so, but I got to tell you, another hat I wear is I'm president of the Minnesota Board of Dentistry. And currently, both of the education programs in Minnesota are working for quota accreditation, but right now we do their accreditation. And when we went in to do their reaccreditation late last year, one of the things that we commented on was both of the master programs are very heavy in credits. Your average master's program sits about 32 credits. Both of the master programs at both the University of Minnesota and Metropolitan State were sitting between 40 and 44 credits. And as the accrediting body, that is one of the things we ask them to look at. Is there anything you can do to reduce the number of credit hours that needs to be accomplished to get this degree? It's much more difficult in healthcare. I think you'll find that in medicine as well. It's maybe easier in different fields because one of the things that really adds up for anyone who goes into the healthcare field is clinical hours and clinical practice, which you want to have before you graduate, and cutting those down, you know, you want to make sure you're also protecting the public and that you have a practitioner that's been properly supervised through the training process, and that's where they really have a hard time paring back those hours.
Good morning. So this may be directed more toward Jordan because he's from the state, but as a hygienist formerly, I'm sure you could answer. I just graduated dental hygiene school last week. I start my first job tomorrow, so I'm very excited. For the state of North Carolina, there has been a contentious history between the Dental Society and dental hygienists, and the scope of practice in North Carolina for hygienists is one of the lowest in the country. So I see there may be a hard path going forward for dental therapy in North Carolina. So with that being said, access to care is clearly what we're most concerned with. We want to help the people of the state. So are there any ways that you could see access to care being expanded, either through hygienists or in other forms? Do you have any comments on that?
Well, I think if we're talking about healthcare at large, I think there's other policies that, can certainly help expand access to care. But, if we're talking about and kind of thinking about the question from the gentleman in the back about the two-tiered system, I mean, like I said, 74 of the 100 counties are designated as health professional shortage areas for dental professionals. So, it's what we've seen in the past is that there's just not enough dental practitioners out there. So this is just an opportunity to, open up the opportunity or open up the chance for this license designation to put practitioners on the ground. So, whether that's I don't think that's the only option, but I think that's certainly a critical option for us to help expand and, yeah.
I'm also a dental hygienist, but I would like to know how the dental hygiene profession's been affected in Minnesota. Where are those providers? Are they still allowed to practice to their scope? As he was saying in North Carolina, we don't have a large scope of practice, but I feel like we can, as hygienists, do more. So what is the relationship? Where are they used in Minnesota at this point?
So we're fortunate in Minnesota, we do have a large scope of practice. We even license our dental assistants. They're not just certified, they're licensed in our state. So we really respect all of the dental professionals we have in our state. I'm very proud of that. Like, as a hygienist, we're allowed to do so much. You certainly can work with a collaborative management agreement as well. And it's not uncommon for our hygienists to go into schools and do full scope of care in in those schools. So we're very fortunate that way. I would love to see more states head that direction, because there's some of the most underutilized professionals I think dental hygienists are in a lot of states. We're fortunate in Minnesota. We really do try and utilize those. We also have REF certified if you go back in school, and I've utilized those professionals. I was utilized as a dental hygienist for REF. For those of you who don't know, REF is restorative expanded functions, where a dental therapist or a dentist will go in and prepare the tooth, and an assistant or a hygienist can come in and do the filling. So we're very lucky that way. For me, I still use my hygiene license. It's not uncommon for me to see a little munchkin where they need a cleaning, 4 sealants, an extraction, and a filling. And for those of you who work in public health, when you got those kiddos in your chair and they're having a good day, you get done everything you can, and I will get done everything I can on those munchkins. So I absolutely still utilize my hygiene license. There's a handful of practitioners who are not dual licensed, because in Minnesota that used to be what the university would graduate. A little bit of a disadvantage there, but I think most of those people landed in either private practice or settings where they always have a hygienist available to them.
Just a question, if you're working under the supervision of a dentist, do dental therapists in Minnesota have to have their own malpractice insurance, or are you working under the umbrella of the supervising dentist malpractice insurance?
So yes and yes. We do have to be insured, as do hygienists. In my particular practice, we carry one umbrella policy that covers all of our practitioners. But one thing that we have found is dental therapists who are dual licensed are very inexpensive to insure. For those of my cohorts who've gone out and bought their own malpractice insurance, it's somewhere in the range of $150 a year. So for those of you who are dentists, you can imagine how much money that would save. And part of it is just the long tradition of the safe practice of dental hygiene and the low liability that hygiene has always shown, and the fact that they are still ultimately, in the state of Minnesota, the dentist is responsible for everything their dental therapist does, just like they're responsible for their hygienist and their assistant. So with that liability piece being there as well. We have not seen any increases to our malpractice insurance with dentists signing collaborative management agreements.
Jordan, I've got a question for you. As and I left my notes over there, but there are numerous states who are considering this, considering legislation. Can you talk a little bit about where those states are? Are states in the South, our neighbors, considering it? And what are the challenges that these states are finding?
Well, as Sal will tell us more, Florida has been trying to get the dental therapy profession introduced, and I think this year New Mexico tried to get or passed, but a lot of the states are out west or up north. There's not really, besides Florida and North Carolina, none that I'm aware of that have tried to do this. And I think with a lot of things in healthcare where we've had a status quo of regulation for a long period of time, that there's some natural fear and uneasiness about changing the laws, but I think we'll see some groups that are opposed to this, but like we said, these other states that have passed it, they've seen benefits, and people aren't dying because they're being treated by dental therapists.
No deaths.
No deaths.
0 deaths.
Christy, when you see a fee-for-service patient, is your fee the same as the dentist?
It is.
And you're reimbursed at the same Medicaid rate as a dentist?
We are.
So I fail to see the financial gains by the state or by the patient if seeing a therapist or seeing a dentist. We have 2 dental schools in our state. ECU's mission was to have dentists go to the underserved areas. They've now graduated 5 classes, and we're going to be interested in seeing where those dentists are locating, because whether it is a therapist or a dentist, the cost in those areas is going to be the same. And if the Medicaid reimbursement rate is 39% of the fee, whether it's a therapist or whether it's a dentist, it's going to be somewhat difficult for them to maintain a practice in that area.
So 2 things I would say to respond to that. Number 1 is, no, I don't save the state of Minnesota money. Who I do save money to is my employer. And we are a nonprofit dedicating to serving those most underserved. And what we do, because there are 7 therapists that work for our organization and 5 dentists, they would be looking at employing 12 dentists to do that entire workload, which would be tremendously more expensive and quite frankly wouldn't happen. So what we are able to do is expand the number of children that we can see and expand the number of services that we can give those children at a lower cost to the organization, which keeps our doors open. Because if it weren't for generous donations from foundations and grant work, we wouldn't keep our doors open and 35,000 children wouldn't get care. So yes, when people ask me, how do you save the state money? I don't save the state money. What I do is I help kids. The only way in which I can help save money is the situation I talked about there, right? I kept a kid out of the emergency room. That does cost the taxpayers more, and I know it's a lot harder to try and figure out that money. And to what I would say to any dentist who isn't real keen on this idea, remind yourself, you don't have to hire a dental therapist, but do you think it's your role to make sure nobody else can? Because opposing that legislation, you might be hurting a nonprofit that can help, just like ours does, access to care to a lot of kids and get more services. No one's ever going to tell a dentist they have to hire a dental therapist. I think it's in their best interest, both financially and free market-wise. But please, please consider whether or not you want to stand in the way of someone else being willing to try this model.
Hi, Christy. I know you had mentioned early on that the Dental Society was not in favor, but they have turned
I'm
180,
shocked.
right? But my question is, who were early adopters that were advocates for this in Minnesota? So my background, I was in Michigan when the conversation started around dental therapy. And the academic institutions were a very big part of pushing that along. And so I'm just curious, from the Minnesota perspective, who were the advocates, whether it's national or state?
Who were some of the advocates?
Who were some of the big advocates that were helping assist this along through the
So in Minnesota, we have a huge
legislation?
safety net coalition. Everyone involved in the coalition signed on to help support it. Certainly many nonprofit dental clinics, right? The organization that I work for was a huge advocate, Apple Tree Dental, those who are really dedicated to serving the underserved. So that's I will say that's who our biggest supporters were. I will also say that they were also the early adopters, right? When we're still trying to figure out how you bill insurance, like they were the ones who were like, we'll dig in and we'll figure out how to do it, and then they taught other people how to do it, right? I can't tell you how many times my executive director, once I was working full-time and we had integrated everything in and figured out the scheduling, how many private practice dental practices she talked to help them figure out how to do it, right? So like Health Partners, for example, they were supportive of the legislation, and we had called them to say, how do we do billing through you guys? And they're like, oh yeah, they're talking about that legislation. We're like, no, that legislation passed 2 years ago. So just trying to work through those bumps and grinds. They were also the early adopters.
Great. So did you have support from your state's Medicaid office, for example, in terms of discovering how that would impact the state's burden in Medicaid?
I don't recall. I've never had that question. You guys got good questions here. I don't get stumped very often. No, I do know that there was no fiscal note attached to dental therapy. I mean, it's an expansion of the dental force that didn't have any fiscal note tied to it. So is that helpful?
It is, yeah.
Yeah.
Thank you very much.
All right, we're going to take this opportunity at this point to have the break. But if you have more questions for Jordan and Christy Joe, please keep them in mind because they will still be up there for the panel discussion that follows the lunch. All right, well, we wanted to make sure that everyone had time to converse, think about what they had heard during the first part of the discussion before we got going again. This will be the post-luncheon part of the presentation. And as I said earlier, we're not going to go all the way till 1 because we know there are a couple of folks, including members of the panel, who need to be in other places at 1. So we'll probably go to about 12:45 or so. And I'm sure there are some folks here who will be able to take your questions afterward if you have something you'd like to ask outside of the formal context. You have already heard from Jordan Roberts and Christy Jo Fogarty. They will be around for additional questions. But before we get to resuming the Q&A, we wanted to welcome the 2 additional members now to the stage. Not Sam, but Sal Nuzzo with the James Madison Institute in Florida.
I've answered to worse.
That's worse. And Senator Jim Perry, who represents Lenoir and Wayne counties. And we thought before we got to Q&A, we would give both of them an opportunity to talk a little bit about their experience with this issue of dental therapy. As has been alluded to, Florida, where Sal works, has been talking about this now for a while. And so, Sal, if you would tell us about your experience in Florida in trying to enable dental therapy to take root there.
Sure. Well, thank you very much for having this event. I was remarking in the luncheon that it's rare when we host these events. We're typically far more surrounded by friends, and so I really like the fact that the dialogue and the debate is kind of robust, and it helps, I think, all of us sharpen our arguments for why we oppose or are in favor of a particular policy solution. So my name is Sal Nuzzo. I have the pleasure of being one of the, I like to say, the chief policy nerd at the James Madison Institute, which is a free market think tank in Florida. We focus on state-based policy in Tallahassee and beyond. I do quite a bit of work in DC as well. What I wanted to kind of unpack for you is more of a political story, kind of the last couple of years in Florida as we have begun to kind of address a very big shortage that we have, not just in oral healthcare, but in healthcare practitioners across the spectrum. And so to give you a bit of background, I don't see very many Florida people here. A little bit about our legislature. We have a 60-day legislative session. They are on a hard stop. It just finished 2 weeks ago, so I am under the strict no-tie rule, which doesn't have to pick up again until January, so I'm pleased about that. Our legislature has a House of Representatives at 74-46 Republican Democrat and a state Senate that's 27-13 Republican Democrat. JMI and I have worked on healthcare policy for at least the past 5 years and even beyond that. And what we found in 2018 moving into 2019 was kind of this stars aligned kind of period where we had a brand new governor who won by the skin of his teeth. We avoided an outright socialist for governor. Ron DeSantis came in with an incoming class of freshman legislators In the House alone, there were 44 new House members of the 120. We have term limits in Florida, so the new crop of legislators was far bigger than we had seen in the past. And in addition, they were led by a speaker who serves 2 years, and our new speaker, Jose Oliva, decided to make market-based and market-centered, patient-centered healthcare reform his top priority. And so we had been working in healthcare in kind of a very broad portfolio of things where we focused on the supply issues inherent. Florida has a growing population. We grow about 1,000 individuals a day. We are currently the 3rd most populated state, and we are woefully short on practitioners. So over the last several years, I'd kind of dug into some data that's been published by national groups and trade associations, and we're in the bottom, we're like 35th in number of primary care physicians per capita. We're 31st in specialty surgical physicians per capita, a few other ones. And so this growing population is not getting access to get in to see a doctor, regardless of what they're looking to receive care for. Then you couple that with the fact that Florida's medical school population is in the bottom 10, and that's after doubling medical school enrollment between 2000 and 2010. So we have this critical issue that's been bubbling for several years. And so we had been working on a number of the market-based reforms that I know North Carolina has considered in the past, things like certificate of need reform or outright repeal, expansion of telehealth services, and some other kind of market-centered reform ideas. Back in 2017, we had gotten approached about taking a look at specifically the shortages in oral health care. And so we didn't have the bandwidth in terms of staff to kind of work with a scholar in-house, so we worked with some folks and began to take a look at these things. And in 2018, we published a policy study. We worked with Jennifer and some other folks from various organizations around the country to kind of shine a light on what the numbers were saying about people being able to access healthcare or oral care. What we found is something very similar to what North Carolina was seeing. It's something like 51 dentists per 100,000 Floridians. We're way down in kind of the per capita numbers there. We were seeing of the 67 Florida counties, 63 of them were identified as dental health shortage nationally areas. We had some areas within that range where there was not a practicing dentist within a 1-hour drive of certain residential areas in the state. And so some of the things that we began to look at are, how does this drive overall healthcare spending? Because as Christy Jo had pointed out, as Jordan's pointed out, these ultimately are cost drivers, both intermediate and long-term, as things begin to start in the mouth or in the teeth, and then they spread to other areas. You also have the issue of emergency room visits, and I won't rehash that. But what I'd like to do is talk you through what we encountered and experienced as we began to say, this is a really good idea that Florida should consider. And I would preface this with saying something that Christy Jo really hammered the point home toward the end. This is not meant as a panacea. It's not the silver bullet. It's not the only thing that healthcare policy people should look to and say, this is going to solve all of the shortage issues we have in our state. But it is one thing that we can look to in the toolbox of ideas that are going to get patients care, which is ultimately, regardless of where you fall on this issue, ultimately we all want the same thing. We want people to get care. So we released the study in 2018, and we began to build a small coalition. We worked with some friends, people we knew. It was a new idea. We had recognized that Minnesota had kind of gone through the process and were expanding out their program. And we wanted to really see in year one how much traction we could get in the legislature. Now, we knew the House would like it a lot. They were very innovative in market policy-wise. They were going to be an early adopter. The Senate, on the other hand, we recognize politically they're a lot more cautious. They're not the early adopters on policy ideas. They probably would want to, their first question would be, tell me 15 other states that have done this successfully, and then we'll begin to build support behind it. So our idea was, let's just push and see where we get resistance and whatnot. And as we expected, the Senate wasn't really too keen on it. However, we thought kind of midway through, as it began to get a committee assignment, and it went before its first committee hearing, they changed the idea from let's see what we can do to get a study, a full-blown study approved and funded in the state of Florida that would address not just dental therapy, but overall dental shortages in Florida and multitudes of ways that they can be addressed. And so we thought this was a fairly good idea, and we got pummeled. We showed up to the committee, we had all of our notes, and about 80 folks that had been kind of recruited in by the Florida Dental Association came in, all filling out speaker cards, all telling legislators that this was a bad idea even to conduct a study, because they knew that the only solution to be brought to bear on this was their idea of student loan forgiveness. Forgive student loans for dental students as long as they serve in rural communities, and you will solve the whole shortage problem. The House kind of backed off. They didn't get the study funded in the end, and we kind of decided, all right, well, let's take another look at this. We knew we were probably going to have some pushback. We didn't anticipate it would be that aggressive. So we said, let's build this up because we really do, as we unpacked it more, we really did feel like this was a great opportunity for Florida specifically to address a lot of the shortages. So between 2018 and 2019 legislative session, which was March to May of this past year, we built a bigger coalition. We brought in folks from the dental hygienist community, a number of stakeholder groups that kind of worked with lower income folks that were kind of suffering a lot of the shortages in care. And what we found was, at the grassroots level, the policy was incredibly popular. And so the coalition built, we worked again to update the study, and we put out a more robust version of it in early 2019. But what we did in addition to that was we put forward a campaign. We partnered it and complemented that with ed board visits, a couple of press conferences, a big healthcare event, much like this one, but that was broader than just dental therapy. Op-eds in all of Florida's 10 major media markets. We did radio, podcasts, we had grassroots support for it. We thought we had a whole lot of traction moving ahead. So the House, when new Speaker Jose Oliva had delivered his first State of the House address in the chamber, articulated a number of healthcare priorities that he was going to address in his 2 years as Speaker. Scope of practice expansion was one of those, and he mentioned dental therapists, among others, in there. Again, we were surprised at the level of support that we were getting. The Senate, as I mentioned, was more cautious, but they did agenda the bill for a committee hearing, which was a great step ahead. When we've worked Certificate of Need repeal in Florida, which we just got this year, we got that after 6 years of pushing on it. So to get even a hearing in a very cautious Senate, we thought, wow, this is going to be much better and much more successful than we had envisioned. And it was around that time that I think the Florida Dental Association realized that this was going to gain some steam if they didn't begin to hit back. And hit back, they did. So we kind of got put in place as the lead organization behind the coalition, and we became the face of their opposition. Like, everything that they did had one intent and purpose, and that was to, kind of come after JMI based on our kind of proposal for the policy idea. And we brought it on ourselves. We were the lead group on the policy study. We were the ones speaking at press events. We were the ones doing op-eds on this. We were the ones kind of generating a whole lot of the grassroots support. So every single piece of their legislative strategy involved coming after us. So I began to get calls from dentists around the state that wanted to tell me why this was such a bad idea. And I took every one of those calls and spoke to some of them for as many as 30 or 45 minutes and addressed every concern. A couple of them I turned around and a couple of them I didn't. But dentists started joining our coalition. Practicing dentists, when they learned more about it, decided, you know what? I don't even know if I would hire one of these folks, but I think some other ones might, and it might begin to address the problem. So the FDA's legislative booklets, their emails to all of their members all had JMI in there and had our phone number and our website and our email addresses. And I was remarking last night, I said, the best part of this was I was leaving the office, it was early March, and I get a call and it's from our board chair. Now, I'm the policy geek. We don't get calls from the board chair. So I pick up the phone and he says, you know, Sal, this is Jeff. And I'm like, yes, I know. How can I help you, sir? And he says, I need you to explain to me so that I could respond to my dentist who wants to know why JMI has this crazy idea for dental therapists. And I'm like, wait, you're getting calls from your dentist? He said, yeah, my family dentist called me at my home to want to bend my ear about why this was such a bad idea. And so I said, you know, I know you're busy, so let me send you the paper, and please read it, and then let's talk in an hour or two. So I sent him the paper. I called him back, and he laughed, and he said, this seems like a really reasonable idea. Why would my dentist not like it? In fact, I think my dentist would probably want to hire a couple of these people. And so we helped walk through that. But part of why I think, you know, this is a helpful gut check is, as you are policymakers deciding the direction for North Carolina or, you know, in other states, as you are kind of working at a stakeholder level to build support for a relatively innovative policy idea, you've got to have a good understanding of what you're going to be working up against as a special interest group kind of feels threatened on this type of a thing. And it has worked itself out in certificate of need with hospitals. It's worked itself out in telehealth with the, what we call in Florida, the eyeball wars. The optometrists hate the ophthalmologists and they'll never meet again. And so this is the next front on providing innovative approaches to patients needing to get access to care. And so with that, I want to make sure I don't filibuster and give the senator some time.
Before we turn it over to the senator, and he'll have some interesting comments as well, not just as a policymaker, but in his professional life, being involved in this industry. A couple of notes. Anna would get mad at me if I forgot to mention that we have plenty of food, so please, if you would like to get another plate, head on back there. We have plenty for you, and it's fine to be informal as we're continuing. The second thing is, if you have questions about the report itself, Jordan would be happy to answer them, but it's already been alluded to, but if you haven't seen her, the co-author of the report is also at the front table, Jennifer Majaras of the Texas Public Policy Foundation. So if you have questions about the report itself, feel free to ask Jordan or Jennifer, who are both here. So now, one of the people who would have to make decisions about this as this moves forward would be Senator Jim Perry, who represents Lenoir and Wayne counties, who has an interest in this issue, not just because he's an elected official, but also because this deals with the industry in which he has worked for a number of years. Thank you for joining us, and we look forward to hearing what you have to say, not only about how your professional background affects your interest in this issue, but what you think as a policymaker will have to be answered and addressed before the Senate and House will go along with it.
Yeah, thank you. I appreciate the opportunity to be here. I have spent the majority of my adult life in the dental industry, and I have a lot of relationships with various dentists and dental boards around the country. Our organization had practices under our umbrella in over 40 states and in Puerto Rico, and I was in that industry for about 20 years. So had someone mentioned earlier, contentious relationships, had my share of those in different places. With dental boards or dental societies, and I've also had some fantastic relationships. You know, it's just a cross-section of humanity, and at the end of the day, we are all people. We all have things going on in our lives that make some days fun, some days hard. We've got crazy family members, you know we do, that we deal with. We're all people. And when you start talking about anything related to scope of practice, there's a lot of emotion in it. And I think rightly so, because what scope of practice really is scope of wallet. And there's some purists in the audience, there always are, and they'll say, no, it's not. It's scope of wallet. Those are the biggest issues that we face. Sure, there's some ancillary things that impact it, but anytime you start interfering with someone, the way they earn their income or the way they plan their life, the way you think about someone investing in a dental school education and the amount of debt they take on and starting up a practice, and they go down this road based upon the rules and laws that exist today. So anytime you have lawmakers, and I shudder at that term because I think it means guys like me think we're supposed to get up here and make a lot of new laws, right? Because that's kind of what we do, and sometimes I wish we'd make less and maybe get rid of some of the ones we have, because I really do believe in the free market, and I believe in letting things mature. Having said that, as a policymaker, when I think about this issue, and I think I've got a unique perspective because I think about it in terms of all of the dentists that I've formed relationships with over the years, hundreds of them. I think about the dental hygienist, the dental assistant, everyone in the dental community. And I think about it from a business perspective, from a free market perspective. And when we talk about things in general in healthcare, like certificate of need, I believe certificate of need should be repealed. But there are unintended consequences that maybe some don't have the capacity to consider. Maybe they haven't had the training. Maybe they don't understand it. I think it's the manner in which you do those things. I think we have mid-level providers in North Carolina today. I think you have them in every state today. What it really is about, in my opinion, and that's all it is, it's about delegable duties. And what are the dentists in your state comfortable delegating to what level of training and labor to perform certain roles? I think dentistry as a whole, and this is where my dentist friends get uncomfortable, and this is for everyone except Senator Jim Davis. This does not apply to him. I think dentistry as a whole has been resistant to change over the years. I see it in other professions. It's not just dentistry. It was very difficult to get a dental license in the state of North Carolina for a number of years. I worked for the first man to graduate from dental school in the first graduating class at University of North Carolina, Dr. George L. Edwards. Just a fantastic person, a great story. I remember Dr. Edwards telling us stories about suing the dental board so he could have more than one dental hygienist years ago. Great stories about that, and the fear of change that's normal, and many times it will be for the right reasons, and it will be because someone has legitimate concerns, and then I will hear other concerns expressed. When someone makes the most perfectly horrible argument in the world, either for or against something, that gets really old. You know, we get tired of that. But when we can talk to reasonable people and have reasonable dialogue and conversation on a topic, that is interesting, and I do think that's in the best interest of the people for us to be able to have those interactions. You know, topics like this, do I think, just based on the limited information I have, that North Carolina needs to be the next state to pass laws for dental therapists? No. I wouldn't approach it that way, though. Do I think there could be reasonable conversation about delegable duties? Yes, I do. I look at some laws that I think are, in my opinion, all it is, maybe a bit dated. Maybe they should be reconsidered. But those things they only happen with conversation. I can only imagine how dentists feel when they receive a flyer about a topic like this in discussion today. No, I don't have to. I know how some feel because they they reached out to me when they see my name on that list. Some, not all. You know, there's no association or society that really represents the views of every member. You know, it doesn't happen that way. We have the beauty of liberty and individual thought if we are capable. It's an interesting topic. You know, so I think in some ways it already exists today. It's just to what would you be willing to delegate? What would you consider? You know, you can spend a lot of time engaging in battle head on. Every lawmaker has a dentist. I'll tell you that because I've been on that side of the issue. And the dentist, when they have the lawmaker in the chair, they tend to have a captive audience. It's a little easier for them to get in front of their lawmaker. And they have good relationships with them, and they've been engaged over the years. So it would be an uphill climb to try to have a full frontal assault on any issue like this. But I don't think it's the most effective way. I don't think it's the most effective way to bring about change. I think it is through reasonable conversation. You know, I'm a business guy. I would not want to flip a system on its head overnight and start measuring. We don't do that. We have pilots. We try to understand cause and effect. We want to see what the outcome would be before we spread something. So we would do it in a controlled environment. And those are just my individual thoughts, not from the Senate's perspective. And our Senate, too, is probably a little more cautious on big changes that impact a lot of people when we're unsure of the result. Access to care is an issue, no doubt about it. At one time, North Carolina had 9 of the top 100 cities for dental incomes in the U.S. And people point at that and they say that's terrible. Well, not if you're a dentist. It's a pretty good thing. And I think could be a reflection. You look at the demographics in some of the big cities, they can afford dental care. You know, you come to the poorer areas and it's harder. So I heard and I read in the study, it was mentioned that 2 barriers, one I think was cost and one was access, you know, based on location. I think cost is a barrier for just about everything in our country, not just dental care. And you have some who can afford more than others. That's always been that way. It's always going to be that way. What we found, and in the sector I was in, we treated people lower on the socioeconomic scale. So we treated poor people in more rural areas. We saw a lot of the edentulous population. And while edentulous has decreased in the United States significantly over time, poor people still lose their teeth at the same rate they did 30 years ago. So, and I think, I don't know how you change that. I think some of it's education, some of it is family-based values and what you're taught when you're younger. I've got some family members, you know, I live in rural North Carolina. I can tell you they're not going to the dentist. You can have a mid-level provider, a dentist, we can let anyone provide it, and it's just not part of their culture. It's not part of their family belief. Figuring out a way to work with the dental society to come up with a solution that could provide some expansion of delegable duties, I think is a reasonable thing to discuss, and I think it would gain traction more quickly in the state of North Carolina than a wholesale change and creating yet another degree and more student loan debt and another program. I don't think we're there today. That's just an opinion. I don't have all the answers. Someone mentioned Alaska earlier. I would absolutely 100% vote for a bill like that if I were in Alaska today. I think some care versus no care, that's a no-brainer for me. It seems to make a lot of sense. You know, when I think about our rural areas and the difficulties we have recruiting primary care physicians, as you mentioned, I I think we'd have those same difficulties recruiting any level of provider. We have some pretty desolate, poor areas that continue to lose population, have over the last 20 years with urbanization going on in North Carolina. I don't see that changing. So I guess to wrap it up before I filibuster, feel like I'm in the House, I think that some level of evolution is very reasonable. Everything has a life cycle. Everything has to evolve. I think as our environment has changed and our population needs have changed, it is reasonable to have discussions around what can be delegated and what can't. But I think the wise route is to include the dental community, knowing that some would have 100% resistance. But just like any other group, you're going to find some that are willing to engage in meaningful and reasonable conversation, and I think that's the fastest way to bring change in any state, but certainly on an issue like this.
Okay, thank you. The next thing I wanted to do is, because these two who were with us at the beginning have been sitting here patiently, wanted to offer both Jordan and Christy Joe an opportunity to respond to any of the things that the two panelists who have joined them have said. So if either of you would like to comment.
Yeah, I mean, I'd just like to echo some of the things that I talked about earlier and some of the things that Sal and Senator Perry have said. I mean, when it really comes down to it, I think we're all on the same team in that what we want is to provide opportunity for all of North Carolinians to be able to access health care and especially dental care. And, when we look at the statistics, we see that there are certainly problem areas, and this idea of dental therapy is just one way that we see to address part of that problem. And like we've said, this is not the silver bullet. This is not the end-all, be-all fix. But in our country, our 50 little laboratories of democracy, what we've seen is that in other states, this does have a huge impact on some of the problems that we talked about: rural access, lower income access, and I think that when it comes down to it, we all want the same thing, and whether we get there through dental therapy or something else, this is an opportunity for us to really just expand access through a small fix, and yeah.
I don't have too much to add. I for sure, when you talk about Senator Perry, Alaska, some care versus no care being kind of a no-brainer, I think we all agree with that. You did say, you want to be careful not to flip a system on its head. I don't think that's what we did in Minnesota, and I hope that people don't believe that's what we did in Minnesota. It was a challenge for sure, and I would love to sit down and have a conversation with anyone from any dental association across the country, because I think that in one-on-one conversations, people can be very reasonable and can be understanding that while you may not want to utilize this practitioner, that it could be a great tool in your tool belt. And Sal kind of stole my line that I use when I frequently speak, is I don't ever claim to be a silver bullet, ever. I never have. I'm like that really good wrench you always go to, right? Just that really good tool in the toolbox that you love having there. And I would warn a little bit of paralysis by analysis. I know Senator Perry spoke of doing a pilot program. There's over 1,200 studies that show that there's quality care in dental therapy from across the world. 52 countries use dental therapists and utilize them. There are even pilot programs in Washington and Oregon in our own country that we could turn to. I don't know that we need to necessarily reinvent the wheel unless you're trying to look at something other than quality and safety and adaptability. But those have been studied pretty thoroughly and pretty hard, and I would caution people who think that studying more is going to give you a different result unless you're asking a different question. And most of the questions about dental therapy have been asked and answered.
Thank you. Sal, I also saw jotting down a few notes. Was there anything else you wanted to add? Okay, we're good. I hope there are some continuing questions out here. We'll get to those in just a bit. I will throw out the first couple, and I will pepper with some more questions if you all don't have them. So have good questions. You won't have to hear mine. But the first one, I wanted to go back to something we talked about. Those of us who met briefly on this last evening mentioned it a couple times. It came up a bit during the beginning of this session as well. How much of a challenge with dental therapy is linked to the name, where people just don't get what dental therapy is? You mentioned your degree was as an oral health practitioner, and there was some thought about maybe practitioner would have been better to use than therapy, because people think, you know, you're going in, lying on the couch and talking about your teeth and what your mom
I'm asked
thought
that
about
every
it.
day.
Yeah.
So do you talk to teeth and try and make them feel better about themselves? And the name is challenging. Certainly, it's not what we would have wanted. I'll say, as we went through the legislation in Minnesota, the very first year it was proposed, it did not pass. But the legislature made it very clear to those that were involved, including the Minnesota Dental Association, the University of Minnesota at the time, we're going to move on this next legislative session. You have until next legislative session to come up with a compromise bill. We really prefer dentistry fix dentistry. That dentistry come to us and tell us as a group what kind of a practitioner you would think would serve our communities best. And that's where we came up with that 2-tier, where you start out as a dental therapist and you advance into that general supervision. And another thing that was a part of that negotiation was changing our name to dental therapists versus oral health practitioners. I don't know why the Dental Association felt very strongly that we changed that name, but it mattered a lot to them, and frankly, it really didn't matter a lot to us that we were willing to fall on our sword and lose other things like scope of practice for the title. And of course, since we were the first in the lower 48 to codify it into law, other states have kind of just taken up that language. I don't love the language either. I love my degree because I really feel like it looks more like that nurse practitioner, physician's assistant model, which, I mean, when I sit down and explain my job to lay people, there's not anyone who says, wait, why would dentists let you do that? They get it, right? They all get it because they're all used to many people see their nurse practitioner more than they see their physician. So they get it, lay people get it, and they understand that makes perfect sense to them. You have a little less education, you have a little lower scope of practice, they're very familiar with that model. So I wish we would have kept the name.
How about in Florida? Has that caused any issues?
It hasn't, and I think because a number of states have already kind of gone the route, when policymakers are looking at other states as models, they're seeing the same terminology. But I would echo, I think it's not the hill you want to die on, but yes, it does present a slightly additional challenge to the explanation of it.
I'll ask the senator. You're part of the industry, so that I've heard, I'm sure, the term come up, but if you were talking to your colleagues who have nothing to do with dentistry, not even one of their issues, if you talk to them about dental therapy, do you think there would be just blank faces or people saying, why do we even have to worry about this?
No, I don't think they'd be familiar with the exact list of duties that could be, but this issue has been around long enough. I think people have heard of it.
Very good. One of the other things that came up during the course of the early part of this discussion was the Dental Association in Minnesota sort of flipping from being opponents to supporters. Have the folks in the Dental Association there been amenable to talking to counterparts in other states about, hey, you know, we know you're fighting it, but there's no reason to? Have they been enlisted at all?
Some yes, some no. Some just assume let our state run the way our state runs, and it works fine for us, and you guys figure it out. I do think there's a little bit of, I'm just here to tell a story and let you guys know how it's working for us. We're not going to dictate to any of you what's best for your state, right? Like, you know what's best for your state, and you know the shortcomings you have in your dental system, and you don't. So some will come out and talk about the same thing. They'll tell their story. You know, like I said, I worked with a dentist who vehemently opposed it and came around, and she does spend time testifying and talking to different legislators and different boards of dentistry about her experience and what changed her mind. Most of them, I think, just assume let each state figure it out for themselves.
Anyone else?
Yeah, I think we've had at some of our events, we've brought in both practicing dentists from Minnesota who have brought with them their advanced dental therapists to kind of answer questions, tell the story. And it's a positive and a negative. It is a positive in learning how a particular policy idea kind of plays itself out in reality and on the ground. And at the same time, there's a reluctance from state level policymakers to kind of be even told a story from another state to say, well, first reaction may be, well, you don't know about what we're dealing with in Florida, or you don't understand the geography and the demographics of Florida. And there's absolutely some truth to that. So I think this is an ongoing, like any other innovation, you're going to have states that are early adopters, and then states that wait until it's kind of been proven as a reasonable solution, and then they jump on board, and then you're going to have states that are just going to wait it out until they're the last one. So.
That leads into something I could ask the senator to follow up on. Do you suspect that, given what you know about the Senate, your colleagues, they would more likely to be the ones who would wait till some other states have gone through the pros and cons of this before launching into dental therapy?
So, only Senator Berger speaks for the Senate, but if I had to guess, I would think that we would be more likely to be the slower ones to move on that issue.
All right, well, I can ask some more questions, but certainly we want to have you ask the questions, and all the microphones are taken up now, so I'll just point to folks. The first hand I saw was right there. You'll just speak loud enough to, yep, you sir, yep, and then we're going to get to Representative Blackwell.
So my comment and question is, we're sort of talking around Medicaid reimbursements. It's just not being addressed. Senator Perry said access to care is the combination of cost and access, and I totally agree with that. And Ms. Fogarty works for a group that's a nonprofit that must go out and get grants and must get donations to try to break even because Medicaid will not pay them enough to cover their costs. I practiced dentistry for 40 plus years. I took Medicaid for all those 40 years. A portion of the practice, you lose, sometimes you lose your shirt. So you do a denture, and I do the denture the same way I do for everybody. Medicaid in North Carolina pays 28% of the usual customary reasonable fee, the UCR fee. That doesn't even pay the lab bill for them to process it. So the point is that I think the reason that only 29%, I think was the percentage of dentists in North Carolina take Medicaid, is because two things. One, they lose their shirt. And secondly, is many of the new dentists that are coming up have this large student debt. They cannot afford to do it. I mean, I was in practice a long time, and so you could absorb stuff. You could lose money and make it. And we did it as a community service, just like dentists across the state of North Carolina work on mom clinics. You've all heard about that, and that's $28 million worth of dentistry that's done voluntarily. There are 100 free clinics in North Carolina, many of which have dental components. People go at night and help the access to care issue. So the other point is this, they did a survey and they asked the dentist if Medicaid would cover 65 to 70% of the UCR fee, which would almost cover their overhead. It wouldn't, but it'd come close. 70% of the dentists said in that survey they would take Medicaid. They would work for nothing if Medicaid would help offset the majority of their overhead. And so to me, the other issue to the state legislature is that's also another way to create access to care, is to cover what Senator Perry was talking about, which is the cost aspect of that. And so I just think that needs to be brought up, that no matter if it's a dental therapist or a dentist, if the Medicaid reimbursements are so low, you can't make a profit. You can't go out and practice in the hinterlands because you can't even, you go bankrupt.
Any thoughts about that?
I would agree with a good chunk of what you're saying, and I would push back a little bit in one area. First off, I think, because you'd mentioned student loan forgiveness, or student loans, the debt that comes with dental school, we actually approached through the groups that were lobbying, trying to find a compromise where we would help with and support a limited student loan forgiveness program, which as a free market think tank is kind of antithetical to our philosophy, if it were coupled with even a pilot program for dental therapists in rural underserved areas in Florida, and they balked at it. And so they'd rather have nothing than go that route. On the Medicaid reimbursement rates, yes.
Can you repeat that again? I didn't understand.
They didn't want to compromise on allowing dental therapists in a pilot program and coupling that with a student loan forgiveness program that would relieve the debts for a handful of dentists each year.
Dentists going to underserved.
Yes, correct. So we had that challenge. And to speak to your point on Medicaid reimbursement rates, I would argue, yes, Medicaid reimbursement rates are notoriously low. They're low and they're still driving Medicaid into bankruptcy. And we still have states that are pushing policy initiatives to expand a failing health insurance program that is already on track for bankruptcy. And so we have to look at, in my opinion, and I'm just a policy geek, I have not served in the healthcare industry a day, and I have an untold amount of respect for folks who have to deal with patients day in, day out. But we have to look at how we are going to get people care, and Medicaid is on track to reduce access to care as it becomes more and more fiscally insolvent. So that would be the area to push back on.
Anyone else like to respond?
I would just comment, you're absolutely right about overhead, and to me, that's one of the things that dental therapy can help alleviate, right? In our practice, I said we had 5 dentists, 7 dental therapists. Our dentists make nearly double what we do because we pay them hourly. We don't do a commission-based, right? So that's one of the ways we've tried to manage to keep our doors open in addition to the grants and funding. But so when you talk about you did all those years and you accepted Medicaid, and I agree with you, the reimbursement rate's terrible in most states. But if the person you're paying to do that is less overhead for you, you're going to see a little bit more of this. I've also read a study where there's a couple of states who did raise those rates significantly, and they see a nice bounce right afterwards, and then they see it start to level off, because it isn't just the reimbursement rate, right? It's also an unpredictable population, right? Very high failure rates, things like that, and you have to be able to manage that as well. And even if they're willing to see the patients, there's so many factors that, 30 minutes late for an appointment can throw your entire schedule off for a day, and you still want to give that care. So they do see a nice bounce when they raise those reimbursement rates, but they see it tend to fall off as well.
We're going to get to Representative, you have a follow-up?
Yes, please.
Okay.
So, I agree with you that Medicaid is going bankrupt. And again, we or the government keeps putting more and more people on the Medicaid roll, which they may need, that's fine, but that comes down to, and I'm not a big government person, but the point is, that's either a federal issue or a state issue. And unfortunately, some of that is a federal issue.
Yep.
That where they make the rule and then they send it to Raleigh and say, here, you need to do this, and you come up with money.
Yep.
North Carolina come up with money.
Yeah, we're at an inflection point, or we're approaching an inflection point on healthcare that really was put kind of on that path back in 2009 when the Affordable Care Act went through. And I don't want to debate, it's a different topic for a different day, but we're getting to that place where you have this kind of unfunded mandate coming from the federal governments to the state legislatures, and it is developing into critical mass that I would say pouring more people into that already troubled system is only going to exacerbate the pace at which it crashes.
So in fairness, the access to care issue and cost is not just about the Medicaid population. You know how many people in the country have dental insurance, how many people have a dentist. We've hovered around maybe half, get to 60% at times. I mean, it's never been great, and some people have phobias of the dentist. Some people live in rural areas, and they just don't don't make it a priority. It was never a priority for them from their parents. They have bad habits. You know, there's a lot that plays into that. I think Medicaid certainly can be expressed as part of the issue. I was going to offer maybe we should go Medicaid plus 77% on the reimbursement. I mean, maybe that would do it. That seems to be a popular thing in the state of North Carolina right now, but little inside joke on some healthcare policy.
Okay, so it's too bad Treasurer Falwell's not here right now. Representative Blackwell had a question.
This question may ramble a little bit, but hopefully it'll end up making sense. For sake of discussion, let's say North Carolina decided that we were going to license therapists, but we needed to define in some manner what kind of educational preparation is going to suffice to get us what we want. Recognizing in doing that we are always confronted with the arguments that patient care demands more, patient and quality of care demands more, but we're also confronted with the argument that the more you require, the more expensive it gets, and the more restrictive you end up in terms of the number of people who can get into what it is you want more of. How do you guys suggest we determine what the needed education is so that we don't end up with more or less, but we're in the sweet spot?
Well, I mean, as Christy Joe is saying, there's a model now by CODA, the Commission on Dental Accreditation, that recommends, the guidelines of what the education should be. And in our report, we talk about, that there can be a minimum level of education that still provides that same patient quality and safety that, is required of dentists, but we can get people out of school and on the ground practicing quicker. So you're right. I mean, I think Christy Jo could probably speak to more of the specifics, but in our report we recommend a very flexible, a very more free and less rigid requirements for getting these practitioners on the ground.
So I don't disagree with you. As I said, as a Board of Dentistry president, we've looked at the number of credits that are required to get that master's degree. We're on the high level, and we don't like that. Unfortunately, for any state now, they do have to look at those CODA requirements so that those students come out of an accredited program. That's good and bad, right? Because it gives us a nice guideline. It helps form scope of practice to be a little more consistent between states, things of that nature. I believe the CODA requirements is 9 semesters. It might be 8. It's somewhere right in there that is required, because you have to remember they're going to accredit both the program in Alaska and the University of Minnesota, right? So Minnesota is 27 months after the 10 credits, and Alaska is 2 years post-high school. So there's a lot of flexibility for you guys to build the kind of provider you want. There is not one state that has passed dental therapy legislation that looks exactly like another state. So that's the beauty of it in a way, right? You can tailor it completely to look and reflect what your state needs and what you want. CODA is going to guide you a little bit on the educational requirements, but a lot of that's going to depend on exactly what scope of practice you want to give those practitioners.
I think Senator Davis had a question.
Okay. Senator Davis.
Thank you. My name is Jim Davis. I'm in my 9th year of the state senate in North Carolina, but I'm in my 45th year in dentistry. And so I've been at this a while. I started out in general dentistry in '74, and I took Medicaid patients until I found out that half of them didn't show up, and the ones that did show up were late. And I couldn't see filling out all that paperwork just to lose money. And so I just decided to treat a segment of the population for nothing. That was easier than going through all the Medicaid bureaucracy. I applaud the conversation that we're having to expand, to address the shortage of primary care providers. This scope of practice or delegable authority has been going on for about 50 years that I know of. When in California they were fighting over expanded duty dental systems. And so I think this scope of practice will continue to evolve, but I think it's important like we'd be far better served to increase the dental school classes and reduce the cost of education so that more people can graduate without overwhelming burden of debt, so that they could go to these self-shortage areas and give them whatever loans that they have, give them forgiveness of those for practicing in those areas. So that's what I've got to say.
I think reducing the cost of that education, it's clearly gotten out of hand when you think about the debt loads that these young people are graduating with. And I'm not really thinking on the forgiveness side. I mean really reducing the cost of that education as we've been trying to do in the state of North Carolina. But continuing down that path is very important. I think that's a great point you made.
And one of the other things nobody's referenced, and I'm guessing you would as being a practicing dentist for so long, in Florida we have some of the most egregious tort laws in the entire United States, and medical malpractice insurance premiums are a huge driver for some of the pockets where we are unable to get people, or where dentists are not, because the money just is not there, and medical malpractice premiums are driving a whole lot of that. So we've begun to kind of unwind some of that, but it's a long, slow, arduous journey. I would contend there are ways in which, for areas in Florida where that radius does exist, there are ways that through things like what Minnesota is doing with mobile labs and kind of mobile clinics, where folks can get into those underserved communities and begin the process of getting competent care to those folks.
As a follow-up to that, I would like to say as a policymaker, we are really behind in North Carolina. The Dental Society, I'm very proud of my profession. They've emphasized prevention more than any other healthcare provider since the beginning of time. But the Dental Society is ahead of the legislature. Now they would like to have legislation to allow dental hygienists to give anesthesia. But the legislature is not there yet. And so I think it's, I don't know about the Dental Society in Minnesota, but not all dental societies are alike. And I'm very proud of our Dental Society in North Carolina. They're advocating for expanded duties, but competent expanded duties, and the legislature is behind them, so for what it's worth.
Ma'am?
I have sort of a follow-up comment to that other question. But yet, if you look, for as far ahead as we say our dental society is, the legislature is so far behind. If you look, North Carolina is one of, I think it's still 3 states that has the most restrictive practice for even our competent providers who have proved on a national level what their education competency is. It's that restrictive in the area that's supposed to be for prevention. So that's just a follow-up to that statement. If you just look at that, that kind of shows you how far we are behind other states for what's already competent providers.
I just wanted to kind of circle back to what you had said. I mean, I completely agree. I wish that we were producing more dentists as well, and I wish that they could come out with far less debt. It's a huge burden, and as I said earlier, it's one of the most expensive professions to go through school. I would push back a little bit when you said, like, the example Sal had given about a person an hour away from their dentist, and that doesn't help them. That's precisely who we help. The vast majority of the patients that I see, my dentist isn't with them. And after the number of years you've been in dentistry, there's many, many patients. All they may need is a cleaning, x-rays, preventative stuff, and maybe a filling or 2. I can meet all of those needs, and they don't ever have to see a dentist physically. Obviously, I'm working in collaboration, and my dentist is well aware of the things that I'm doing. We're going over cases and things like that. So the dentist is very aware of what I'm doing, but they don't need to physically be there. And I can help that community. I can go into that community. When it gets above my scope of practice, they're gonna have to make that hour drive, but the fewer people I can make that drive, the more people that are gonna have access to care. So I just wanna clarify that a little bit. That's precisely what we do in the practice that I do, is we go into rural communities without the dentist.
We're going to wrap this up in just a bit, and most of the panelists will be here for individual questions, but since we do have some folks who need to get to 1 o'clock meetings, what I'd like to do is give each of the panelists time for just a very brief response to this. So we're having this conversation. There's no legislation out there today. I don't think anyone thinks we're going to pass anything about dental therapy anytime soon. But what is your hope of what happens now that we've had this conversation today? I'm going to let the senator go first because he's the one who has to get out of here the quickest. So after hearing this conversation, what do you hope, if anything, happens next?
Well, you know, I think it's a first conversation of many. Being open to consider changes, you know, to adapt to the environment we have today, I think is very important. I think Senator Davis indicated he's had discussions about different roles and maybe expanding some abilities to handle some other things for patients. I think following up on those and having those conversations are important, and trying to work with instead of against any organization is usually the fastest way to bring about change. Because when you have warring factions, it tends to freeze things up, and it's better to have those communications up front. So thank you for your time today.
I would say this is a spectacular venue and event because we have done collectively what I have urged so many people both in DC and in the States to do. And that is, when we talk about healthcare, we have to get away from talking about it like it is not an economic good. Healthcare is provided by people, it is provided by facilities, it is provided by instruments, it is provided by pharmaceuticals. All of those things are subject to the laws of supply and demand. And the more that we can keep the conversation structured in a way that, yes, we all want to talk about the human side of healthcare and making sure that people are getting better, but at the end of the day, ultimately, it is a discussion about supply and demand and the laws of economics, and how do we get more people in to a chair or into a hospital or to a doctor for higher quality service at the most affordable cost. So to the degree that folks have been here disagreeing, I love it, because it helps us fine-tune the argument that we make. And my hope is ultimately it allows us all to eventually come together at a reasonable policy solution that legislators in whatever state you're in can address. So.
I feel like I've done a lot of talking, but I really just want to say thank you for having me here and letting me talk about the story in Minnesota. I encourage all of you, just like these gentlemen, keep talking about it, figure out what's best for your state. This works in Minnesota, it works great in Minnesota, and we have one of the most complicated pieces of legislation that passed. The ones that came after us are so much cleaner. So continue to work on it, continue to have the conversations, and I agree with Senator Perry. Don't go to war on this, find a way to come together. I believe it was New Mexico that just passed the last piece of legislation, and their dental association did support it. You know, frankly, legislators want us to tell them how they can help fix dentistry and make dentistry more accessible and better for everyone.
I'm sure Jordan would say, read the report, but what else?
Well, read the report for sure. But you know, what I hope everyone takes away is that dental therapy has nothing to do with therapists and therapy, but you know, these are unique mid-level practitioners, and you know, I think we have a perfect example here of that. All the good and benefit that they can bring with these supervision requirements, supervision agreements. They can go out and practice in a non-traditional setting, and I think that's what we're trying to show here, is that in North Carolina we do have a very large portion of the population that's secluded from crucial healthcare access, and you know, allowing people to come in and be open and free to treat patients the way they want, just like Christy Joe has in Minnesota, can only benefit these patients. And you know, I hope we can, you know, continue the conversation and come to that sweet spot of policy where we just add another designation of health professionals that can increase the supply and meet the unmet demand that we have in our state. So thank you.
All right, let's thank our panelists, please. One more comment.
I just wanted to add one thing. Being from eastern North Carolina and listening to Senator Davis's wise words, I do think it'd be great to double the number of spots at the dental school at East Carolina University. I want to make sure I get that recorded and all of my constituents hear that.
All right, thanks again. And on behalf of the John Locke Foundation, thanks for taking part of your time to be here today. Please read the report. Stay tuned. We'll be keeping up on this and other healthcare issues. Thank you again.